All right, guys, so now we're going to move on to a pharma symposium. We have Professor Eike Wustenberg, and he's actually joining us from Germany, so that's great. He is a professor in otorhinology and allergy, and he's done a lot of research in allergic diseases, both in the upper and lower airways. So we'll go ahead and have him share with us. Let's welcome him.
Yeah, assalamu alaikum. Thanks a lot for inviting me, and I really hope that you can hear me. So today I want to speak about the house dust mite. We have learned a lot about biologics today, and now we will go a little bit more back to the origin of the disease. And this immunotherapy, first my declaration of conflict of interest. So as you already heard, I'm a specialist for ENT and also had neck surgery and allergology in Dresden and also in Hamburg in Germany. So here on the left-hand side, you can see the wonderful panorama of Dresden city. Dresden was completely destroyed in the Second World War, but it was now rebuilt and it's really beautiful. So if you should come to Germany, you of course should visit Dresden. It's really a beautiful city. By the way, this is the ENT clinic here. And on the lower part of this picture, you see the Elbphilharmonie from Hamburg, and here in Copenhagen, where the head office from ALK is sitting. There you see Amalienborg Castle. This is the castle where the Queen lives, and this is the headquarter building of ALK. And why do I show to you this slide? Because I'm also affiliated to ALK, where I'm heading the medical department there. So these are the three topics where I want to speak about. The first is some general aspects about house dust mite respiratory allergy. Then I want to show to you some clinical data of a house dust mite SLIT tablet for immunotherapy. And then, of course, I also want to give you some practical recommendation for the use of this tablet. So let's start with general topics about house dust mite allergy. I think you all know house dust mites. House dust mites are everywhere, and they love it humid, they love it warm, and they live in the warm and humid climates in tropical areas preferably, but they also live in the Emirates. And they love to eat skin scales and fungi. And because of the skin scales, they also love it in your bed. They are present everywhere on your carpets, they are present on your clothes, but they also love your bed. And this is the reason why many patients get symptoms also in the night. And they have two parts of these mites are allergenic active. On the one hand part, it's the fecal parts of these mites, and on the other hand part, it's the body particles of the mites. And if we are then looking and asking ourselves, are the mites at all relevant for the United Emirates? There I show you a study where 1,200 subjects were screened, and out of these 1,200 subjects, 85 were diagnosed having allergic rhinitis. And it was looked for which allergens cause this allergic rhinitis. And what you see here is that house dust mite are the most frequent cause for allergic rhinitis in the Emirates. Close to 60% of the patients are diagnosed with house dust mite allergy, but also in the polysensitized patients, you can see that here house dust mite plus grass pollen, house dust mite plus pollen plus animal, house dust mite plus animal. House dust mite play really the major role for allergic rhinitis in the Emirates. And then we have also to think with which symptoms do the patient present with. So half of your patients will present with allergic rhinitis only, but the other half will present with allergic rhinitis plus allergic asthma. And only very few will only present with allergic asthma symptoms. If you compare this part here of patients 50% with allergic rhinitis plus allergic asthma, this is comparably high if you compare this to seasonal allergens. And why is this so high? It is so high because you have a perennial exposure to the allergen, meaning you have this allergic inflammation of the nose all year round, and you know that this inflammation from the upper airways can progress into the lower airways. And of course, if we have a perennial exposure compared to a seasonal exposure, this inflammation is much more chronic, and therefore the likelihood to progress into the lower airways is much higher. So allergic asthma is also very, very important for house dust mite allergy. And if we are then looking for with which patients do the patients really present, just to show a patient here. So on The eye symptoms, they can get sore eyes, meaning feeling like foreign bodies in the eyes, gritty eyes, itchy eyes, so that the patients go and rub their eyes. But this is not the leading symptom. The leading symptom are the nasal symptoms. It's the blocked nose. And a blocked nose, and this I can tell you as an ENT physician, there are so many reasons for a blocked nose. Yeah, and this means it's really, really difficult to diagnose house dust mite allergy. So with which additional symptoms can be present? It also can give this typical allergy symptoms like repetitive sneezing or difficulties breathing and cough in the morning as the first sign of getting asthma. And if you look for these symptoms, a blocked nose, repetitive sneezing, this sounds a little bit like having an infectious cold, or maybe even a little bit like getting COVID. Yeah, so it is very unspecific, these symptoms, and some patients only present because they come to you and say, oh, I always have a cold, and this cold a normal cold is away after 1 or 2 weeks, but if I have a cold, it's always 3 to 4, maybe even 5 weeks. So the patients misinterpret this house dust mite allergy symptoms. They misinterpret this as having a cold. So these are some very unspecific symptoms where you really should look at, and then really it's a matter of thinking for it. Yes, it might be house dust mite allergy, and then do the respective testing with IgE testing or with a prick test. And all these symptoms can occur in the bed because the bed is warm and humid and there are the skin scales. And this means the patients sleep quite bad. And this means the patients are too tired for work. And this means they are impacted also in their daily activities. So this is something quite relevant. And if we look how impacted the patients are, again, some data from the Gulf region, where 234 patients were asked in a rhinitis questionnaire, what symptoms do you have and how severe are these symptoms? Approximately 3 out of 4 patients report that the symptoms of the patients are moderate to severe. Approximately half of the patients report that the symptoms are uncontrolled. 30 to 40% of the patients report they have problems at work or at school, or they have problems in life or leisure activities, or in the family's life or in the home responsibilities. So this is quite a severe impact of this house dust mite allergy for the patient's lives. And of course, our duty as doctors is we want to help the patients. So the question is, how can we help these patients? And then we have to look a little bit, what is allergy all about? We can compare allergy with a kind of an iceberg. In an iceberg, you have a part above the sea level. And this part above the sea level, these are the allergic rhinitis symptoms. And we already know these allergic rhinitis symptoms, with the time they can progress also to allergic asthma symptoms. And how do we normally treat these symptoms? We treat these symptoms with symptomatic treatment, meaning with antihistamines, meaning with intranasal corticosteroids, meaning with inhaled corticosteroids, or maybe even with biologics, as you already heard before in the presentations before. But all these treatment regimens, they only treat the symptoms of the disease. If you stop the treatment with these medications, then the symptoms will come back because you have not treated the cause of the disease. And of course, it's much nicer for us to treat the cause of the disease. But what is the cause of the disease? The cause of the disease is an intolerance of the immune system. This means our immune system does not tolerate the house dust mites where we are every day exposed to. And the immune system reacts with an inflammation when we are exposed to the allergen. So what should be the optimal treatment for these patients? We should make the immune system tolerant so that an exposure to the house dust mite does not lead to this inflammation anymore. And how can we induce this tolerance to the immune system? We can do it with immunotherapy. In immunotherapy, we expose the immune system to very high dosages of the allergen. And with this, the immune system learns that this allergen is not dangerous and that there is no need to react with an inflammation. And with this treatment, we can get long-term effects. And we also can modify disease, meaning we can prevent progression from rhinitis to asthma, but also we can prevent the progression from a mild asthma to a more severe asthma. And with this, we also can prevent the need for biologics, most likely. And that this is not only a nice story, I show you with some few data. So first, is it really true that we can modify the immune system? You heard in the biologics that you give specific antibodies against specific interleukins. So it's a very specific treatment. Here we have a more broad treatment. We expose the body to allergens, and to be exact, to the allergen where the body is allergic to, the immune system is allergic to. And then we see immediately in a fast increase of blocking antibodies, of IgG4 antibodies, meaning in contrast to the biologics that we heard before, in immunotherapy, the body produces these antibodies itself. So we have a natural treatment where the body produces the antibodies itself. And you see this very fast increase of the antibodies within the first 2 months of treatment. And then if you continue the treatment, this antibody level still increase a little bit. And then if you stop the treatment, then the antibodies are still significantly superior compared to a placebo-treated group. This means, yes, we can induce blocking antibodies in the immune system that protects the immune system from the allergens. And if we stop the treatment, this effect will persist. And how does this correlate into clinical symptoms? If you start immunotherapy, you will get a clinical effect already in the first year. And if you then continue the treatment, you see, as in the antibodies, there is still a slight increase of the effect size. And if you then stop the treatment, the symptoms still are significantly lower compared to the placebo group patients. So yes, we can induce long-term blocking antibodies, and we also can induce a long-term effect with immunotherapy. So now I want to go specifically on this house dust mite tablet clinical data. And let's first see how this tablet is produced. So this tablet consists of the 2 major mite species, Dermatophagoides pterinosinus and Dermatophagus farinae. And I already told you, from both mites, the body particles and also the fecal particles are allergenic active. And therefore it also consists of the body particles and of the fecal particles, meaning it consists of the group 1 allergens and of the group 2 allergens. And each part of this tablet of this allergen is produced separately, and then it is fit together so that we really have each allergenic part is represented in equal parts in this tablet. So this is a really, really high standardized product compared to all other immunotherapy products where the mite simply are in the end crashed and solved in a solution and then standardized everything together. Here, everything is standardized separately and then fit together. And these standardized allergens are then filled into a lyophilizated tablet. And this tablet has the big advantage that it dissolves extremely fast. And I will show you now 2 small videos. On the left-hand side, you will see the disintegration of this lyo tablet. And on the right-hand side, you will see the disintegration of a compressed tablet. Just look at this. And now you put the tablet into water and it's away immediately, whereas the compressed tablet is there for a much longer time. And why is this clinically relevant? This is clinically relevant because if you have a very fast dissolution of this tablet, this means you have a very fast release of the allergen, meaning you have a very strong allergen concentration, and this concentration gradient presses or facilitates the allergen absorption through the oral mucosa. And this tablet was also developed in many, many clinical studies, in phase 1 studies looking for safety, phase 2 studies looking for dose finding, and several phase 3 studies for rhinitis and also for asthma in adults, but also adolescents and also in children. And these studies were performed in Europe and also outside Europe, meaning in Asia, in Japan, and also in North America. In total, much more than 6,000 patients were included in these studies. And I just want to show you the most important study data. First, again, let's start with the immune system. So first question was, can we induce blocking antibodies in the immune system? And the answer is yes, we can. This is an asthma study. This is a rhinitis study. And you see here both mite species, Farina and Pterinosinus, again, Farina and Pterinosinus. And you see here in gray, you see the placebo group. You see with placebo, you do not induce any changes in the immune system. But with active treatment, 2 different dosages, you get a dose-dependent increase of these IgG4 antibodies for both mite species. So yes, we can induce blocking antibodies in the immune system. And again, how does this relate into clinical symptoms? Here first a chamber trial. The chamber trial is very nice because in a chamber trial, you do not have a placebo group. In contrast to all, you don't have to, sorry, you have a placebo group, but you do not need symptomatic medication for the patients. So you have a comparison against a real placebo, but you do not have a comparison against symptomatic medication that you have in normal studies. And how is the study performed? Here you see a room. This is the exposure chamber. And in this room, all the patients are sitting. They have electronic diaries in their hands. And in the room, you have an allergen inlet, meaning the house dust mites are sprayed into this room. And there's an air inlet. And this air inlet ventilates the air so that you have a turbulence airstream so that the allergens are equally distributed in all this room. And what can we see there? We can see there that or how did we do this trial? So we had 124 patients. They were distributed to placebo and 2 different doses of the house dust mite. And every 8 weeks, they were in this chamber. And now we are coming to the results. So you see already after 8 weeks, in the higher dose, you have a 20% reduction of the rhinitis symptoms. After 16 weeks, it's a 30% reduction of the rhinitis symptoms. And after half a year, you have already half, 50% reduction of the rhinitis symptoms compared to placebo. So this is something really significant for the patient to have half the symptoms compared to placebo. And if we then stop the treatment and do a 1-year follow-up, you still see the significant reduction in the higher dose group, that you still have significantly less symptoms compared to the placebo group. So we have an onset of effect already after 8 weeks, and we have also a persistence of the effect even if we have stopped the treatment. And now let's look into asthma. And this study design here, what I will show you here, this is very much aligned with all the biologic studies that you have seen before. So in this study, 834 patients were randomized to placebo and 2 different doses of the house dust mite tablet. The patients were treated with their individual corticosteroid dosages. And then here at this point of time, the individual cortisone dose of the patient was reduced to 50% here. And then after 3 months, it was completely withdrawn. And the primary endpoint was, when does the patient get his first moderate to severe asthma exacerbation? And I will show you the data. So here you see the point of time where the ICS dose of the patient was reduced to 50%. This is here. And what you can see is that the placebo group here in gray immediately starts with asthma exacerbations. And you see that the actively treated group has significantly less exacerbations. And even if you completely withdraw the ICS dose, meaning the patients do not take any ICS anymore, you still see this very strong risk reduction of asthma exacerbations, even if you reduce or withdraw ICS. And how is this reflected again into clinical symptoms? The first thing is the patients sleep better, meaning we have a reduction in the risk of nocturnal awakening, meaning better sleep. It's significant. You have a decreased risk of a deterioration of lung function, meaning lung function improves, also significant. And you also have a reduced risk of using SABA, meaning the patients need less SABA, need less asthma medication. So this is something really clinically relevant for the patients. And this study also with the study, it was also possible to change the GINA guidelines. Maybe you remember before 2017, the GINA guidelines always recommended not to use immunotherapy because it has not a clearly proven effect. And in 2007, for the very first time, GINA mentioned for the very first time that patients with house dust mite allergy, for these patients, house dust mite SLIT should be considered for sensitized patients with allergic rhinitis and an FEV1 above 70%. So for the very first time, GINA recommended house dust mite sublingual immunotherapy based on the study data that I just showed to you. So we have here quite a unique treatment option. We have a treatment option that not only reduces the symptoms, but also is able to modify the allergic pathway, meaning it is also able to prevent this progression from rhinitis to asthma, and is also able to produce long-term effects. And we are able to treat the upper and the lower airways with only one product, meaning we can, if we are looking for the daily symptoms, we can treat the rhinitis symptoms, we can treat the conjunctivitis symptoms, and we also can treat the asthma symptoms. And looking at symptomatic medication, we can reduce the symptomatic medication for allergic rhinitis, we can reduce the SABA need, and we can reduce the need for inhaled corticosteroids. So we treat upper and lower airways with only one product, not using cortisone. And I think this is quite relevant for the patients. And if we are then looking for side effects, of course, they are important and side effects are frequent. Why are they frequent? Because you expose the immune system with the allergen where the patient is allergic to. This means it's quite logical that the patient will experience some side effects. And these side effects are typically a local oral itching, or a throat irritation, or a sublingual edema. But most of these side effects, they are mild to moderate, only very few are severe. And what is really important, because we always have fear with asthma patients. If we look here in this asthma study for the full asthma patient cohort, and here you have the cohort with the patients that were uncontrolled according to GINA. There we normally would expect that the uncontrolled patients have more and more severe side effects. But if we look at these two graphs, this is not the case. Meaning in uncontrolled patients, we do not have more severe side effects. We do not have more side effects. This means this product is also really safe in asthmatic patients. So now to come to the last part, practical recommendations for the use of this tablet. So what does EAACI, the new EAACI guidelines say? The EAACI guidelines say we should only use standardized AIT products. I have shown you the standardization process with evidence of efficacy in the clinical documentation. And I have also shown you some efficacy data. I could have shown you many more efficacy data. They all show exactly the same results. So it's extremely consistent. And which patients should we treat? We should treat patients with symptoms suggested for allergic rhinitis with or without conjunctivitis. And we need an IgE sensitization. And the patient should have moderate to severe symptoms despite the use of appropriate pharmacotherapy. And this is exactly also reflected in the SMPC of this product. So the product is indicated in adult patients with a clinical history and a positive prick test of house dust mite sensitization. And the symptoms should be moderate to severe despite the use of symptom relieving medication, meaning the ideal rhinitis patient is the patient that has taken antihistamines. The antihistamines did not work or did not help him enough. He still has symptoms. So this is the right patient for this tablet. Of asthma, it's exactly the same if the house dust mite allergic asthma is not well controlled by inhaled corticosteroids. Meaning it's a patient that is already on inhaled corticosteroids, but still has the cough in the morning. This is the ideal patient for this tablet. And in adolescents, there is the rhinitis indication. So it's again the patients that have rhinitis symptoms despite the use of symptom relieving medication. And which patients should not be treated? These are the patients with the FEV1 below 70%, but after adequate pharmacological treatment. Meaning if a patient has not treated, has not used his inhaled corticosteroids in the last 3 weeks, and therefore the FEV1 is below 70%, then first the patient should be compliant again, use the ICS, and if the FEV1 is then above 70%, then you can start. And then the second patient that you should not start is patients that have experienced a severe asthma exacerbation in the last 3 months. Severe asthma exacerbation means that the patient were in hospital due to an asthma exacerbation. And also patients that have an acute respiratory tract infection. In these patients, you should wait until this infection is healed, and then you can start with the treatment. So now I will come to a patient case that you see how a typically course of this treatment works. So this is a 45-year-old female lady, and her leading symptoms were quite typical. She had nasal obstruction since approximately 10 years. She tried nasal corticosteroids, but she still had symptoms. And it's very typical that the patient have the symptoms since many, many years. So 10 years is not unusual. She also had recurring and prolonged infections in the winter. So these were no real infections. These were symptoms of the signs of the house dust mite allergy. And since half a year, she also had cough in the morning. And this was also the reason why she visited me. We did the prick test and we did the IgE, and this was positive on both mites. And therefore, she had the ideal indication for the treatment with the house dust mite SLIT tablet. So we did the first intake already in 2017. The first intake should always be in the doctor's office. And she experienced some local oral itching. But this was tolerable, so there was nothing to worry about for her. So she continued the treatment at home. The itching disappeared until the next visit. I typically do the next visit after 3 weeks for the represcription. And then I also can speak with the patient, how did the side effects develop? And the itching was completely disappeared. And she had a strong improvement of all symptoms after approximately 3 months. She stopped the treatment in 2020, and until now, she is nearly completely symptom-free. So this is the quite normal course that you will see in your offices. It's important to educate the patient in the right way, because many patients are used to take drugs on the tongue and then they swallow the drugs. But this tablet should be taken under the tongue. It's a sublingual tablet. So don't take it on the tongue, lift your tongue and put the tablet under the tongue. And then most likely it will start to itch under the tongue because of the mode of action. So this is totally normal. It's a good sign, this itching, because it shows that the immune system reacts to the allergen. The first intake should always be in your office. If the first intake is tolerated well, you can continue at home, and you should do a follow-up visit after 3 to 4 weeks to discuss with the patient how the side effects disappeared with the time, to motivate the patient to continue with the treatment. So many patients are used to normal painkillers, meaning they have headaches, they take the painkiller, they have no side effects, and 1 hour later, the headache is away. So this is what the patient expects from a normal treatment. But here we have a totally different mode of action. It starts typically with some side effects, with this local itching. The side effects disappears then within the first 3 weeks, but only after approximately 8 weeks, the patient will experience a clinical effect. And the patients that are not informed, they get the impression, oh, I only have side effects, but I have no clinical benefit. Why should I take this product? So it's important to explain to the patient how this treatment works. And just to come back to this slide, it's important to explain to the patient how the immune system works, and many patients do not understand the immune system, and therefore I really like to explain it with a picture of training for a marathon. So if you're training for a marathon, in the beginning you get really muscle sore, it really hurts, and these are the side effects in the beginning here. So this is the muscle sore, but the longer you train, meaning you take the tablet every day, the less the muscle sore becomes. But also the longer is the distance that you can run. And to run a marathon, the training also takes several weeks. So this is a quite nice picture that the patient understands. So just looking at the reimbursement, the product is reimbursed in most European countries and also in the important European countries. And just as a very last summary slide, why do I personally use this tablet? For me, it's important, as also for the Eike guidelines, that I have a product with really documented efficacy in rhinitis and also in asthma, because asthma and house dust mite allergy is so frequent. So I want to have a product that treats both rhinitis and asthma. And it's for me also important because most of my patients are polysensitized. It's also important that the product is also able to treat the polysensitized patients. I have not shown to you these data in the polysensitized patients, but effect size is exactly the same, independently if you have monosensitized or polysensitized patients. The product is also approved by many authorities all over the world. And for me, the most important are the FDA and European medicines agencies, and it's approved by both of them. So there I really can be sure that this product is working and this product is well documented. It is in Germany, it developed to the #1 house dust mite AIT product, by far the most prescribed AIT product for house dust mite allergy. And it also has the full reimbursement in many European countries. I like it very much that it's very convenient because you have no updosing anymore. You have the first intake in the office, but you already start with a full dose and you have no updosing. This also means that you can switch to this product from many other products without any updosing. Just the first intake is in your office, and this makes it very convenient for the patient and for you. You have a better safety profile compared to subcutaneous immunotherapy, meaning you have less systemic reactions. You do not need any cooling. And it's really time saving. You do not have all these updosing injections as for subcutaneous immunotherapy. You only have the first intake in the office, and then every 30 or 90 days you have the represcription. And if the patient really has understood the treatment, how it works, then it's only a handshake. Hello, how are you? Oh, you feel better. Wonderful. Here's your next prescription. So this is really time saving, and this means you can treat many more patients in the same time. And what I also experienced that during Corona times, this home treatment was very beneficial for the patients and also for the doctors. Thank you very much for your attention.